Topic for discussion today is diseases of the dental pulp. We shall be discussing it under the following headings. Dental pulp is a formative organ of the tooth which produces primary dentin during development of the tooth, secondary dentin after tooth eruption, reparative dentin in response to stimulation as long as the odontoblasts remain. The pulp consists of tiny blood vessels, lymph, myelinated and unmyelinated nerve fibers. D- Diseases of the dental pulp can be classified as pulpitis, that is an inflammatory disease of the pulp, which is subclassified into reversible and irreversible. Reversible pulpitis is classified as symptomatic and asymptomatic, whereas irreversible pulpitis is classified into acute and chronic. Acute is further divided into abnormal response to cold and abnormal response to heat. Chronic is further classified as asymptomatic with pulp exposure and hyperplastic pulpitis. Further, Grossman classified it as pulp degeneration, which consists of calcific, atrophic, and fibrous, and pulp necrosis. According to Grossman, the etiology of pulpal disease is physical, which includes mechanical and thermal. Mechanical may be due to trauma, pathological wear, cracked tooth syndrome, and periodontalgia, whereas thermal may be due to heat from cavity preparation, exothermic heat from setting of the cement, conduction of heat and cold through deep filling without a protective base, frictional heat caused due to polishing of restoration. The chemical reasons are phosphoric acid, which is leached from dental dentures, and also acrylic monomers, which we use during different restorations, whereas erosion is caused by different acids which are due to carbonated drinks that the patient consumes. The bacterial causes involve toxins associated with caries, direct invasion of pulp from caries or trauma, and microbial colonization in the pulp by blood-borne microorganisms, which is also termed as anacoresis. The different physical causes include mechanical injuries, which may include trauma, which may or may not be accompanied by fracture of the crown or root. Injury may be accidental or iatrogenical. Accidental blows include violent blow during a fight, sports, automobile accident, or household accident, and different habits like bruxism, nail, and thread biting. Iatrogenic causes include during cavity preparation and rapid orthodontic tooth movement. Pathological wear may be related to attrition, abrasion, bruxism, abstraction. Occlusal trauma may also injure the pulp because of repeated irritation to neurovascular bundle. Another feature is the cracked tooth syndrome, which is incomplete crack or fractures that occur to the body of the tooth and pain of idiopathic origin. Pain ranging from mild to excruciating at irritation or release of biting pressure is a classic symptom. A diagnosis may be made by reproducing the pain by asking the patient to bite on a rubber wheel or a tooth sleuth. Cracked enamel is visualized using a dye or by transluminating the tooth with fiber optics. Periodontalgia is a pain experienced in tooth due to low atmospheric pressure. Irreversible pulpitis may be caused due and it may be symptomless at ground level. Pain may occur at high altitude because during ascent, the trapped gases may expand and enter the dental tubules, which stimulate the nociceptors of the pulp, resulting in tooth pain. Thermal injuries are produced mainly from heat due to cavity preparation. Temperature change produced during cavity preparation with an increase in temperature of up to 20 degrees Celsius in temperature may up to 1 millimeter from the pulp. An increase of 30 degrees Celsius may cause zero point 0.5 millimeter from the pulp during cavity preparation. High-speed tungsten carbide bar or diamond bar reduces operating time but accelerates pulpal death if used without a coolant. The degree of pulpal response is inversely proportional to remaining dentin thickness. Remaining dentin thickness is a key factor in determining if the changes are reversible or irreversible. Heat conduction for filling. A metallic filling flows to the pulp without an intermediary base may conduct the temperature changes rapidly to the pulp and may destroy the pulp. Frictional heat during polishing may also be a cause for transient pulpal injury and cause reversible pulpal injury. Physical causes or electrical agents, that is mainly galvanic current produced due to dissimilar metallic restorations, may generate heat and cause pulpal damage. The different chemical agents are key factors which determine the pulp reaction to a restorative material. Acidity, heat generation during setting reaction, remaining dental thickness, absorption of water during setting, and poor marginal adaptation of the material may contribute to bacterial leakage. Bacterial agents mainly enter the pulp through a break in dentin or from developmental grooves or from percolation around a restoration or from extension of infection through open blood vessels, lymphatics during infection, diseases, or bacteremia from gingiva. Anachorosis is bacteria circulating in bloodstream which tend to accumulate at sites of pulpal inflammation. One probable cause of this phenomenon is increased capillary permeability in this area. These are the main causes for dental diseases or diseases of the dental pulp. Now we come to the diseases of the dental pulp per se in detail. Before that, we have to see what are the sequelae of pulpal diseases. Mainly, if the normal pulp is irritated by any noxious stimuli, it may cause reversible pulpitis, which when untreated may lead to irreversible pulpitis, which can lead to different type of pulpal diseases, which includes chronic hyperplastic pulpitis, symptomatic irreversible pulpitis, asymptomatic irreversible pulpitis, or internal resorption, which may all lead to pulpal death. Further, the normal pulp can develop directly due to degenerating changes in the pulp and cause calcific degeneration or calcific metamorphosis. Reversible pulpitis is a mild to moderate inflammatory condition of the pulp caused by noxious stimuli in which the pulp is capable of returning to uninflamed state following removal of stimuli. Etiology may be trauma, thermal shock, excessive dehydration, chemical irritation, galvanism, or excessive orthodontic forces. The irritant that cause hyperemic or mild inflammation in one pulp may produce secondary dentin in another if irritant is mild enough. The pulp is vigorous enough to protect itself. Short, sharp pain is a main symptom which is momentary and most often brought on by cold than hot food or beverages or cold air. And the diagnosis can be done by clinical test and patient symptoms and visual examination and history in which caries, restoration, fracture, or traumatic occlusion may be noticed. Percussion test will react normally and also palpation and mobility will be normal. In radiograph, periapical tissue shall be normal. And vitality test, there may be electrical pulp testing shows minimal current to initiate positive response due to increased excitability. There may be mild hyperemia to moderate inflammatory changes limited to the area of the involved dental tubules, and histological changes may show reparative dentin, disruption of odontoblasts, and dilated blood vessels. The differential diagnosis may be due to elaborated by thermal tests, which are useful in locating the affected area of the tooth as a reversible pulpitis, responds readily to cold. The treatment is prevention and periodic care to prevent the development of caries. Any early restoration, if a cavity has developed, should be performed, and use of cavity varnish or a cement base before insertion of a restoration. Once symptoms are subsided, tooth may be tested for vitality to make sure that the pulpus necrosis hasn't occurred. It has a favorable prognosis. Irreversible pulpitis is a persistent inflammatory condition of the pulp, which may be symptomatic or asymptomatic. The most common etiology is bacterial involvement of the pulp or chemical, thermal, or mechanical injuries, or if reversible pulpitis is left untreated. In early stages, there may be paroxysm of pain that may be caused by sudden temperature changes, particularly cold, sweet, or acidic foods. Pain persists for several minutes to lingering after removal of stimuli, and it is described as a sharp, piercing, shooting type of pain, which is generally severe and which may be increased on lying down or bending down because of increase in intrapulpal pressure. In later stages, there may be severe pain which is boring, gnawing, or throbbing, and nocturnal pain which is intolerable despite the efforts of analgesia. Apical periodontitis is absent except in later stages when there is inflammation of the periodontal ligament. Diagnosis is by a study of the patient's symptoms and by clinical tests. In visual examination, there may be a deep cavity that is extending to the pulp. Percussion test. Usually, the tenderness implies an increased intrapulpal pressure as a result of hyperactive exudative inflammatory tissue. The radiograph may not show anything significant and may disclose an interproximal cavity or caries. There may be mild response or may respond the same as reversible pulpitis during thermal test. As pulp inflammation progresses, heat will intensify the response because it has expansive effect. An electric pulp test may be positive, and a response to less current may be expected in early stages because of low threshold of alpha A delta fibers. In histopathology, there may be acute as well as chronic changes, and continuous vasodilation may be noticed, and chondroblasts are destroyed. Localized destruction of the pulp by polymorphonuclear leukocyte cells and formative of microabscess may be noted. During asymptomatic stage, there may be exposed pulp and it exhibits little or no pain except when the food is packed. Hence, while during an EPT, it may require more current than the control dose. In early symptomatic stage, less current is required to elicit a response in electric pulp test, and pulp is abnormally responsive to cold. In later stages, the symptoms may simulate those of acute alveolar abscess, in which there may be it can be differentiated from acute alveolar abscess because there will abscess will have swelling, tenderness to percussion, mobility, and lack of response to vitality tests. The treatment for irreversible pulpitis is complete removal of the pulp or pulpectomy. And if the tooth is unrestorable, it may lead to extraction of the tooth. Generally, it has a favorable prognosis if endodontic therapy is initiated at the earliest. Chronic hyperplastic pulpitis is produced by the pulpal inflammation due to extensive carious lesion of a young pulp. It is characterized by development of a granulation tissue covered at times with epithelium and result from low standing, low grade irritation. The etiology is slow progressive carious response and a pulp polyp may be formed because there is a large open cavity and a young resistant pulp and a chronic low grade stimulus which is necessary. Symptomless due to except during mastication when the pressure from the food molars may cause discomfort. Diagnosis can be done because it occurs on children or young adults, and the pulp polyp is clinically characteristic of a flesh-ready pulpal mass, which most often fills a pulp chamber or cavity or extends beyond the confines of the tooth. Radiograph may show a large open cavity and vitality test. Usually the thermal test, the tooth may respond feebly or not at all to thermal test unless extreme cold such as ethyl chloride spray is used. In histopathology, the surface is covered with stratified nervous epithelium and granulation tissue is young, vascular, connective tissue containing PMNs, lymphocytes, and plasma cells. The pulp tissue may be chronically inflamed. The appearance of hyperplastic pulpitis is characteristic and should be easily recognized. The disorder must be distinguished from proliferating gingival tissue. The treatment includes removal of the mass, followed by using a periodontal curette or spoon excavator, and bleeding can be controlled with pressure. The pulp tissue of the chamber is then completely removed and a dressing of formicosol is sealed in the contact with the radicular pulp tissue. And further, if time permits, the entire procedure of pulpectomy may be done in a single visit. The prognosis is generally unfavorable, but the prognosis of the tooth is favorable after the endodontic treatment and adequate restoration. Internal resorption is idiopathic, slow, fast, or progressive resorption that occurs in the dentin pulp due to trauma. The patient symptoms may include internal resorption of the tooth, may be asymptomatic. Sometimes it may be manifested as a reddish area, also known as the pink spot or pink tooth of memory. The reddish area represents the granulation tissue shown through the resorbed area of the crown. In histopathology, we can see osteoclastic activity and the resorptive process is characterized by lacunae, which may be filled by osteoid tissue, which is generally regarded as an attempt to repair. Multinucleated giant cells or dentinoclasts are present and the pulp is usually chronically inflamed. The diagnosis may be done. It may affect either the crown or root or the tooth or may be extensive throughout the may be slow, progressive, extending over 1 to 2 years, or it may develop rapidly and most readily seen in maxillary anterior teeth. The radiograph may show changes in appearance of the walls in the root and the canal or pulp chamber with a round or ovoid radiolucent area. It may be differentiated when the internal resorption progresses into periodontal ligament space, a perforation of the root occurs. It is difficult to differentiate from the external resorption. Extirpation of the pulp stops the internal resorptive process and routine endodontic therapy may be performed. In many patients, however, the condition progresses unobserved because it is painless until the root is perforated. In such a case, calcium hydroxide paste is sealed in the root canal and is periodically renewed until the defect is repaired. It has a fair prognosis or a guarded prognosis and depends on the formation of a calcific barrier or access to the perforation that permits surgical repair. Pulp degeneration are of usually two types, and early stages of pulp degeneration shows no signs or symptoms. But as degeneration progresses, the tooth may discolor and pulp will not respond to stimulation. It is of two types, calcific and atrophic degeneration. In calcific degeneration, part of the pulp tissue is replaced by calcific material, and calcification may occur either within the pulp or root canal, but it is generally present in the pulp chamber. Calcified material has a laminated structure and lies unattached within the body of the pulp and even attached to the wall of the pulp chamber. It is not possible to distinguish one type from the another on a radiograph. According to position and structure, pulp degeneration can be classified. It may be classified as free, attached, or embedded. The structures may be true or false, and pulpstones that are similar to dentin are called true pulpstones, and false dentin pulpstones are calcified masses arranged in lamellar fashion around a nidus that do not contain dentinal tubules. There is also calcific metamorphosis that occurs due to degeneration of the pulp space and may occur as a sequelae to traumatic injury. Such a response to trauma is characterized by rapid deposition of hard tissue within the canal space, and the teeth may be asymptomatic and may exhibit discoloration of the crown. Atrophic degeneration is observed histopathologically in pulps of older people, and few stellate cells and are present and intercellular fluid is increased. The pulp tissue is less sensitive than normal, and no clinical diagnosis exists for the same. Fibrous degeneration is characterized by replacement of the cellular element of the pulp, and pulp has a leathery fiber-like consistency and no distinguishing clinical symptoms to aid in diagnosis. Finally, necrosis of the pulp is the death of the pulp, and it may be partial or total depending upon the part of the entire pulp is involved or not. Necrosis can be caused as a sequelae to inflammation and follows in traumatic injury. Most frequently, the etiology may be associated with bacteria or traumatic injuries. There are two types of necrosis. One is coagulation necrosis, in which only soluble portion of the tissue is precipitated or converted into a solid mass. Caesation is form of coagulation necrosis, in which the tissue is converted into a cheesy mass consisting of coagulated proteins, fats, and water. Liquefaction necrosis, which results when proteolytic enzymes convert into the tissue into a softened mass or a liquid or amorphous debris. Finally, the end products of pulp decomposition include hydrogen sulfide, ammonia, fatty substances, indicam, water, carbon dioxide, and intermediate products of pulp decomposition involves indole, scatol, putrescine, and cadaverine. The main symptoms of pulp necrosis are there are no painful symptoms. Discoloration of the tooth is first indicated that the pulp is dead, and the tooth lacks its usual brilliance, luster, and translucency. Presence of a necrotic pulp may be discovered only by chance because such a tooth is asymptomatic, and teeth with partial necrosis can respond to thermal changes owing to presence of vital nerve fibers. The diagnosis is made by a radiograph in which we can see absence of tooth absent in a tooth with total necrosis, and radiograph includes thickened periodontal ligament space. The swelling, mobility, and response to percussion and palpation are negative, and there is no response to vitality test as well. In histopathology, we can see necrotic pulpal tissue, cellular debris, and microorganisms that may be seen in pulp cavity. The treatment is the proper treatment is necrosis is thorough canal debridement, that is root canal treatment, followed by observation of the root canal, and it has a favorable prognosis if endodontic therapy is done. To conclude, pulp is also a formative and highly resistant organs of the teeth. Pulp is among the most densely innervated and vascularized tissues in the human body, and the microcirculatory system serves several essential roles in maintaining the vitality of the pulp. Both these systems are critically important in maintaining homeostasis of the dental pulp, and the value of the pulp as an integral part of the tooth, both anatomic and functional, should be recognized, and every effort should be made to conserve it. These are the references. Thank you.